Global considerations in multiple myeloma. So the incidence of myeloma, so this is highest in blacks and Pacific Islanders. So where is the incidence of myeloma highest? In blacks and Pacific Islanders. And Chinese and Japanese, so they have a lower incidence than whites. And immunoproliferative small intestinal disease with alpha heavy chain disease is most prevalent in the Mediterranean area. So in the Mediterranean area, immunoproliferative small intestinal disease with alpha heavy chain disease, so this is most prevalent in the Mediterranean area. So, what is the pathogenesis and what are the clinical manifestations in multiple myeloma? Multiple myeloma cells, they bind via cell surface adhesion molecules to bone marrow stromal cells and extracellular matrix. So, these multiple myeloma cells, they bind via a cell surface adhesion molecules to bone marrow stromal cells and extracellular matrix. So because of this, so this triggers multiple myeloma cell growth, survival, drug resistance and migration in the bone marrow milieu. So because these multiple myeloma cells, so they are binding via the cell surface adhesion molecules to the bone marrow stromal cells and the extracellular matrix. So this is triggering multiple myeloma cell growth, survival, drug resistance and migration in the bone marrow milieu. So this is the multiple myeloma cell. So this is attaching to the bone marrow stromal cells. So these are the adhesion molecule interactions. Multiple myeloma cell, bone marrow stromal cell. So these are the adhesion molecule interactions. So these effects are due both to direct multiple myeloma cell, bone marrow stromal cell binding via adhesion molecules and to induction of the various cytokines. So because of this binding, so what are the different cytokines that are induced? Multiple myeloma cell, so this is binding to the bone marrow stromal cell and these are the cytokines which are induced. So these include interleukin 6, vascular endothelial growth factor, IGF-1 and SDF1. Interleukin 6, vascular endothelial growth factor, IGF-1 and SDF1. So these are cytokine mediated signaling. RAF and after this, so this is activated RAF and JAK-STAT3. And induction of various cytokines include interleukin 6, insulin-like interleukin 6, insulin-like growth factor type 1, vascular endothelial growth factor and stromal cell derived growth factor 1A. So because of this multiple myeloma cell, bone marrow stromal cell binding via adhesion molecules and induction of various cytokines including interleukin 6, insulin-like growth factor type 1, VEGF and stromal cell derived growth factor 1A. So growth of the cells, drug resistance and migration. So these are mediated via RAS-RAF mitogen activated protein kinase, PI3K AKT and protein kinase C signaling cascades respectively. Growth, it is mediated by RAS-RAF mitogen activated protein kinase. Drug resistance is through PI3K AKT and migration it is to protein kinase C signaling cascades respectively. So RAF so this pathway for proliferation, JAK-STAT3 pathway for drug resistance and anti-apoptosis and PI3K pathway for cell cycle and PI3K AKT and this is for migration. Other cellular elements in the bone marrow microenvironment also significantly impact multiple myeloma cell growth and survival. So the other cellular elements in the bone marrow microenvironment, so they also significantly impact multiple myeloma cell growth and survival. The major myeloma supporting interactions are with endothelial cells and osteoclast. The major myeloma supporting interactions, so these are mainly with endothelial cells and osteoclast. endothelial cell and osteoclast. What are the signaling pathways? RAS, RUF, mitogen activated protein kinase, PI3K, AKT, and protein kinase signaling pathways. Immune cells such as plasmacytoid dendritic cells, myeloid derived suppressor cells, and T helper cells are increased in number and support myeloma growth. What are the immune cells? The immune cells such as plasmacytoid dendritic cells, myeloid derived suppressor cells, and T helper cells. So these are increased in number and they support myeloma growth. While anti-myeloma immune responses, especially T helper and cytotoxic cells, B cells, and natural killer T cells are suppressed. So which are increased in number? Plasmacytoid dendritic cells, myeloid derived suppressor cells, and T helper 17 cells are increased in number. So bone pain, so this is the most common symptom in myeloma, affecting nearly 70% of the patients. Bone pain, so this is the most common symptom affecting nearly 70% of the patients. Persistent localized pain, so this usually signifies a pathological fracture. So if that pain is persistent for a prolonged period of time, so this signifies a pathological fracture. The bone lesions of myeloma, so these are caused by proliferation of tumor cells, activation of osteoclasts that destroy bone, and suppression of osteoblasts that form new bone. So why the bone lesions of myeloma? So these are caused by the proliferation of tumor cells. Tumor cells are proliferated, activation of the osteoclasts that destroy the bone, and suppression of the osteoblasts that form new bone. The increased osteoclast activity. So why this increased osteoclast activity? So this is mediated by osteoclast activating factors, so produced by the myeloma cells. No, they produce this osteoclast activating factor. So because of this osteoclast activating factors, osteoclast activity is increased. So this activation of osteoclastic activating factors, so these are mediated by several cytokines like interleukin 1, lymphotoxin, vascular endothelial growth factor, receptor activator of nuclear factor K beta ligand, macrophage Th17 inhibitory factor 1 alpha, and tumor necrosis factor. So these are several cytokines: IL-1, lymphotoxin, vascular endothelial growth factor, receptor factor of nuclear factor rank ligand, macrophage Th17 inhibitory factor, and tumor necrosis factor. So the bone lesions are lytic in nature, and these bone lesions, they are rarely associated with osteoblastic new bone formation due to their suppression by Dickhoff produced by myeloma cells. So these osteoblastic cells are suppressed by DKK1. So this is produced by myeloma cells. So here this myeloma cells, they produce DKK1, and because of this production of DKK1, osteoblasts are suppressed. And so this rank ligand, so rankel is produced by osteoblasts, and here it is rank. So because of this, there is a proliferation, differentiation, and increased activity of this osteoclast. So rank ligand is activated, and so therefore radioisotopic bone scanning is less useful in diagnosis than is plain radiography. So because of this suppressed osteoblastic activity, radioisotopic bone scan is less useful in diagnosis. So because of the bony lysis, what will happen is there will be a substantial mobilization of calcium from the bone. Bony lysis is occurring because of this mobilization of calcium from the bone is occurring, and serious acute and chronic complications of hypercalcemia may dominate the clinical picture. Because of lytic lesions, so acute and chronic complications of hypercalcemia, it will dominate. So localized bone lesions, they cause a collapse of vertebra leading to spinal cord compression. So if there are any localized bone lesions, they cause the collapse of the vertebra. So this will lead to spinal cord compression. The next most common clinical problem in patients with myeloma, so this is susceptibility to bacterial infection, which is the next most common clinical problem, susceptibility to bacterial infections. What are the most common infections? So these are pneumonias and pyelonephritis. What are the most common infections in multiple myeloma patients? So these are pneumonias and pyelonephritis, and the most frequent pathogens are Streptococcus pneumonia, Staph aureus and Klebsiella pneumonia in the lungs, and Escherichia coli and other gram-negative organisms in the urinary tract. So what are the most frequent pathogens? So these are Streptococcus pneumonia, Staph aureus and Klebsiella pneumonia in the lungs, and Escherichia coli and other gram-negative organisms in the urinary tract. So in 25% of the patients, recurrent infections are the presenting features, and greater than 75% of patients will have a serious infection at some time in their course. Recurrent infections and a serious infection, that is at some time in their course, almost greater than 75% they'll have a serious infection. So why this susceptibility to infection? This has got several contributing causes. So first, patients with myeloma, they have this diffuse hypogammaglobulinemia if the M component is excluded. So we exclude that M component. So if we exclude that M component, patients with myeloma, so they have this diffuse hypogammaglobulinemia. Why this hypogammaglobulinemia? So this is related to decreased production as well as increased destruction of the normal antibodies. So what happens to normal antibodies? So there is a decreased production and increased destruction of the normal antibodies. So the large M component results in fractional catabolic rates of 8 to 16%. Large M component will be there, no? So this large M component, so this results in fractional catabolic rates of 8 to 16% instead of the normal 2%. So the large M component, because of this large M component, fractional catabolic rate is 8 to 16%. And moreover, some patients, they generate a population of circulating regulatory cells in response to their myeloma that can suppress normal antibody synthesis. And some patients, no, they generate circulating regulatory cells in response to their myeloma. So because of the circulating regulatory cells, what will happen? Normal antibody synthesis is suppressed. So these patients have very poor antibody responses, especially to the polysaccharide antigens such as those on the bacterial cell walls. So these patients, no, they have very poor antibody responses, especially to the polysaccharide antigens such as those on bacterial cell walls. Various abnormalities in T cell function are also observed, including apart from this, even abnormalities in T cell function are also observed. So what are the abnormalities in T cell function? So these include decreased Th1 response, decreased Th1 response, increase in Th17 cells producing pro-inflammatory cytokines, and aberrant T regulatory cell function. So what are the abnormalities in T cell function? Decreased Th1 response. Th1 response is decreased. Th17 cells are increased. So because of this, pro-inflammatory cytokines are produced, and there is a aberrant T regulatory cell function. Granulocyte lysozyme content is low, and granulocyte migration, no, so this is not as rapid as normal in patients with myeloma, so because of the result of a tumor product. So what happens to the granulocyte lysosome content? So it is low, and also the granulocyte migration, so this is not as rapid as normal in patients with myeloma. And there are also a variety of abnormalities in complement functions in myeloma patients. Even in complement functions, so there is some abnormality. So all these factors, no, say they contribute to the immune deficiency in these patients. So even complement function abnormalities. So because of all these factors, what will happen, there is immunodeficiency in these patients, and some commonly used therapeutic agents, they significantly affect immune function. So if you use dexamethasone, no, so this will suppress the immune responses. Dexamethasone is used, so this will suppress the immune response and increases susceptibility to bacterial and fungal infection. And B cell maturation antigen, so antigen targeting chimeric antigen receptor cells. So B cell maturation antigen is there, no? So the chimeric antigen receptor T cells, no? So they can eliminate the plasma cells inducing hypogammaglobulinemia, and bortezomib predisposes to herpes virus reactivation. And if we give bortezomib, so that will lead to herpes virus reactivation. So chimeric antigen receptor T cells, they eliminate the plasma cells, and this causes hypogammaglobulinemia. Dexamethasone suppresses the immune responses and increases susceptibility to bacterial and fungal infection. So renal failure occurs in nearly 25% of myeloma patients, and some renal pathology is noted in greater than 50% of many contributing factors, which is the most common cause of renal failure. So hypercalcemia, so this is the most common cause of renal failure. Glomerular deposits of amyloid, hyperuricemia, recurrent infections, frequent use of non-steroidal anti-inflammatory agents for pain control, use of iodinated contrast dye for imaging, bisphosphonate use, and occasional infiltration of the kidney by myeloma cells, all these may contribute to renal dysfunction. So what are the other factors that are contributing to the renal dysfunction? So glomerular deposits of the amyloid, hyperuricemia, recurrent infections, frequent use of non-steroidal anti-inflammatory agents for pain control, and because we use for pain we use NSAIDs, recurrent infections, hyperuricemia, and iodinated contrast dye for imaging, bisphosphonate use, and also occasional infiltration of the kidney by myeloma cells. So all this will contribute to renal failure. However, tubular damage associated with the excretion of light chains is almost always present. So tubular damage, it occurs due to the excretion of the light chains. So normally light chains are filtered, reabsorbed in the tubules and catabolized. Normally what will happen, there will be filtration, reabsorption, and catabolization of light chains. But what happens here, there is an increased amount of light chains which are presented to the tubule. So because of this increased light chains which are presented to the tubule, the tubular cells, no, so they become overloaded with these proteins. And tubular damage results either directly from light chain toxic effects or indirectly from the release of intracellular lysosomal enzymes. So with the increase in amount of light chains presented to the tubule, what will happen? The tubular cells, no, they become overloaded with these proteins, and tubular damage results either directly from light chain toxic effects or directly from the toxic effects, or indirectly with the release of the intracellular lysosomal enzymes. So the earliest manifestation of tubular damage is the adult Fanconi syndrome. So this is a type 2 proximal renal tubular acidosis. So what is the earliest manifestation of tubular damage? So the earliest manifestation of tubular damage is adult Fanconi syndrome. So this is a type 2 proximal renal tubular acidosis. What will happen here is there will be loss of glucose and amino acids, as well as defects in the ability of the kidney to acidify and concentrate the urine. Earliest manifestation of tubular damage is adult Fanconi's syndrome. So this is a type 2 proximal renal tubular acidosis. So there will be loss of glucose and amino acids, as well as defects in the ability of the kidney So the ability of the kidney to acidify and concentrate the urine, so this is also affected. The proteinuria, it is not accompanied by hypertension, and the protein is nearly all light chain. So in the urine, the protein, what protein will be there, all light chains, and this proteinuria, no, so this is not accompanied by hypertension. Generally, very little albumin is in the urine because glomerular function is usually normal. So when the glomeruli are involved, non-selective proteinuria, it is also observed. So very little albumin because of glomerular function is normal. But if when glomeruli are involved, non-selective proteinuria is also observed. So patients with myeloma, so they have a decreased anion gap. So what happens to patients with myeloma? So they have a decreased anion gap. Sodium plus chloride minus sodium minus chloride plus bicarbonate. So the M component is cationic. So this M component, no, so this is cationic, so this will result in retention of chloride. So because of this, what will happen, M component is cationic, so this results in retention of chloride, so this will lead to decreased anion gap, and this is often accompanied by hyponatremia. So this hyponatremia is felt to be artificial, that is, it is a pseudo hyponatremia because each volume of serum has less water as a result of the increased protein. So what does the type of hyponatremia in multiple myeloma? So it is pseudo hyponatremia because each volume of serum has less water as a result of the increased protein. So renal dysfunction due to light chain deposition disease, light chain cast nephropathy and amyloidosis is partially reversible with effective therapy. So this renal dysfunction due to light chain deposition disease, light chain cast nephropathy and amyloidosis, so this is partially reversible. So this is partially reversible with effective therapy, and myeloma patients are susceptible to developing acute renal failure if they become dehydrated. So multiple myeloma patients, if they become dehydrated, they are susceptible to developing acute renal failure. Normocytic and normochromic anemia occurs in 80% of the myeloma patients. So normocytic and normochromic anemia in 80%. So it is usually related to the replacement of the normal marrow by expanding tumor cells. Why this normocytic normochromic anemia? Because of the replacement of the normal marrow, because tumor cells are expanding, so the normal value marrow will be replaced, and to the inhibition of the hematopoiesis by factors made by the tumor. Hematopoiesis is inhibited by the factors which are produced by the tumor, and there is also a reduced production of erythropoietin by the kidney, and to the effects of long-term therapy. So what will happen? Erythropoietin reduced production, and also because of the long-term effects of the therapy. And in addition, mild hemolysis may contribute to the anemia. Mild hemolysis also may occur. Why this anemia is occurring now? So mild hemolysis contribute to the anemia. A larger than expected fraction of patients may have megaloblastic anemia due to either folate or vitamin B12 deficiency, and a larger than expected fraction of patients, they will be having this megaloblastic anemia due to either folate or vitamin B12 deficiency, and granulocytopenia and thrombocytopenia are rare except when therapy induced. So if any treatment is given for treatment of multiple myeloma, so then granulocytopenia and thrombocytopenia might occur, and clotting abnormalities may be seen due to why this clotting abnormality is due to failure of antibody coated platelets to function properly. Antibody coated platelets, no, they won't function properly, and the interaction of the M component with clotting factor. So antibodies are interacting with platelets, M component is interacting with clotting factors 1, 2, 5, 7, 8. Antibody to clotting factors or amyloid damage of the endothelium. So because of amyloid, so there is a damaged endothelium. So all this will lead to clotting abnormalities. Interaction of the M component with the clotting factors 1, 2, 5, 7 or 8, and deep vein thrombosis is also observed. So the drugs which are used in the treatment of multiple myeloma, so deep vein thrombosis is also observed with the use of thalidomide, lenalidomide or pomalidomide in combination with dexamethasone. So when this thalidomide, lenalidomide or pomalidomide, so the side effect it is deep vein thrombosis. Raynaud's phenomenon and impaired circulation may result if the M component forms cryoglobulins, and hyperviscosity syndromes may develop depending on the physical properties of the M component. So what happens here is Raynaud's phenomenon and Raynaud's phenomenon and impaired circulation. So why does this occur? If the M component forms cryoglobulins and hyperviscosity syndromes, so this will develop on physical properties of the M component. Most common with IgM, IgG3 and IgA paraproteins. The M component could be either IgM, IgG3 and IgA paraproteins. So hyperviscosity is defined based on the relative viscosity of serum as compared with water. So what is the relative viscosity of the serum as compared with water? So this is how hyperviscosity is defined. So normal relative serum viscosity is 1.8. That is, serum is normally almost twice as viscous as water. Serum, no? So this is normally almost twice as viscous as water. So symptoms of hyperviscosity occur at a level greater than 4 centipoises, which is usually reached at paraprotein concentrations of 4 gram per deciliter for IgM, 5 gram per deciliter for IgG3 and 7 gram per deciliter for IgA. So symptoms of hyperviscosity. So when does it occur? So when IgM, if it is at 4 grams per deciliter, or IgG3 at 5 grams per deciliter, and IgA. So IgA should be around 7 gram per deciliter to reach the hyperviscosity to a level greater than 4 centipoises. So the normal relative serum viscosity is 1.8. Hyperviscosity is defined based on the relative viscosity of serum as compared with water. However, depending on chemical and physical properties of the paraprotein molecule, it can occasionally be observed at lower levels. Although neurological symptoms occur in a minority of patients, they may have many causes. So renal clotting abnormalities, anemia, and apart from that, even neurological symptoms also occur in a minority of patients. So this hypercalcemia, no? So this will produce lethargy, weakness, depression and confusion. So because of this hypercalcemia, so this will lead to CNS manifestations in the form of lethargy, weakness, depression and confusion. Hyperviscosity, so this will lead to headache, fatigue, shortness of breath, exacerbation or precipitation of heart failure, visual disturbances, ataxia, vertigo, retinopathy, somnolence and coma. So if there is a hyperviscosity, so this hyperviscosity will lead to headache. Hyperviscosity leads to headache, fatigue, shortness of breath, exacerbation or precipitation of heart failure, visual disturbances, ataxia, vertigo, retinopathy, somnolence and coma. So bony damage and collapse. So this will lead to cord compression. So because of bony damage, so this will lead to cord compression, radicular pain and loss of bowel and bladder control. And infiltration of the peripheral nerves by amyloid, so this can be a cause of carpal tunnel syndrome. Infiltration of the peripheral nerves by amyloid, so this can cause carpal tunnel syndrome and other sensory motor mono and polyneuropathies. Sensory motor mononeuropathy or polyneuropathy. So peripheral nerves will be infiltrated by amyloid. Neuropathy associated with monoclonal gammopathy of undetermined significance and myeloma. So this is more frequently sensory than motor neuropathy. So what is the type of neuropathy which is commonly associated with MGUS, monoclonal gammopathy of undetermined significance and myeloma? It's more frequently sensory than motor neuropathy, and this neuropathy it is mostly associated with IgM M neuropathy MMN. So IgM sensory neuropathy more than other isotypes. In greater than 50% of patients with neuropathy, in greater than 50% of patients with neuropathy, the IgM monoclonal protein is directed against the myelin associated globulin. Why? Because this IgM monoclonal protein, no, in greater than 50% of patients are having neuropathy. So this IgM monoclonal protein, so this is directed against the myelin associated globulin. IgM monoclonal protein directed against the myelin associated globulin. And sensory neuropathy. So sensory neuropathy, so this is also a side effect of therapy, specifically thalidomide and bortezomib. So thalidomide apart from DVT, so this is also known to cause sensory neuropathy, and even bortezomib, so this also causes sensory neuropathy.